So this is the third episode of NextGen mock exam. And today we have with us two very eminent professors, Professor Dr. Jiledar Rawat from KGMU Lucknow and Dr. Satyasri Balija from AIMS Rishikesh. And we have a very proactive student with us, Soumya Kashif, who is going to present a case of lump abdomen. And one request to both the examiners that this exam is basically like any other MCH examination, but at the same time, it is exam-oriented teaching also. So whenever you ask questions and student is not able to reply to that question, then it's better you mention the answers also. There is one little modification we have done in this program. You are allotted 45 minutes for question answer session and completing your case discussion, including management. And another 15 minutes, I will be doing a rapid fire round, which will mostly include imaging of the lump abdomen cases, which I have prepared today. So that I'll show to Soumya, and the participants will also be free to answer in the chat box. And I prepared certain key points of each imaging. So after I've shown the slides and my key points, then examiners can also comment on those images. So now I hand it over to Dr. Soumya Kashif for his case presentation.
So thank you, sir.
You can start sharing your screen.
Yes, sir. Sir, are my slides visible?
Yeah, they are visible and you're audible also. You can proceed.
Thank you, sir. A very good evening to all. I am Dr. Soumya Kashif, resident in the Department of Pediatric Surgery at AIMS Rishikesh. Today, I am presenting a case of an 11 months old male hailing from Sambal, Uttarakhand. The history was given by mother and father whose reliability seemed to be good. The child presented with the chief complaint of lump in abdomen noticed by mother 2 months back. The 11 months old male presented to our OPD with complaint of lump in the right upper abdomen noticed around 2 months back by the mother while bathing the child. The lump was progressively increasing in size and not associated with pain and fever. There was no history of vomiting, loose stool and fever. There was no history of trauma. There was no history of weight loss, loss of appetite or decreased activity. No history of jaundice or pruritus. No history of any bleeding manifestation or hematuria. And there was no history of contact with sheep, cattle or dogs. In the perinatal history, the antenatal scans were normal. The child was a full-term normal vaginal delivery, appropriate for gestational age, and there was no history of any NICU stay. The family belonged to lower middle class. The child was a third born, and there was no history of similar illness in the family or other siblings. The child is immunized for age and has attained normal developmental milestones for his age. On examination, the child appeared active, alert, and playful. The vitals were all within normal limits, and the BP was between 50th to 90th centile as well. Weight was 8.5 kgs, which came at 20th centile, and the height was 75 centimeters, which was around 35th centile. There was no pallor, icterus, lymphadenopathy, or lower limb edema. Neither were there any features of precocious puberty. On abdominal examination, on inspection, the umbilicus was shifted inferiorly and was slit-like. All the quadrants were moving well with respiration. On inspection, there was around 8 by 4 centimeters of lump visible in the right hypochondriac region, which was moving with respiration as well. The overlying skin appeared normal without any visible dilated veins. The bilateral hernial orifices were normal as well. Genitals were normal with bilateral descended testis and well-developed scrotum. There was no renal angle fullness. On palpation, there was no local rise of temperature. About 10 by 5 centimeters of hard, non-tender lump was palpable, which was involving the right hypochondriac and epigastric regions. The surface of the mass was nodular, edges were irregular. It was inferiorly extending around 5 centimeters below the right costal margin in mid-clavicular line, medially reaching midline, laterally not palpable beyond the posterior axillary line. Superior margin could not be reached, and I was not able to insinuate fingers below the right costal margin. There was no renal angle fullness or splenomegaly. There was dull note heard over the entire mass and there was no shifting dullness present. There was no bruit heard over the swelling, normal bowel sound heard over the rest of the abdomen. The other systemic examinations were within the normal limits. So I would like to summarize my case now. It was an 11 months old male, well preserved child with asymptomatic, hard, right hypochondriac lump with nodular surface and irregular edges moving with respiration. We followed the child up with the blood investigations, on which hemoglobin was 10.5. The platelet counts were 738,000. AFP was 92 nanograms per milliliters. LDH 422 units per liters. And beta HCG was 2.4. Following which an ultrasound was done, on which liver was enlarged and heterogeneous in ecotexture with ecogenic areas within, likely neoplastic lesion.
Soumya?
Yes, ma'am.
Rawat sir?
Yeah, ma'am. Yeah.
Before we go to the investigations, can we go back to the summarization once?
Yeah.
Yes, ma'am.
Yeah. Soumya, yes, before we go back, because the investigations now seem to be only pointing towards malignancy from what you're telling me, the tumor markers. Why did you think of it as malignancy in the first place? And what do you think would be the lesion? And what is the organ of origin, according to your clinical examination?
Yes, ma'am. So, an 11 months old child presented to us with an asymptomatic right upper quadrant mass. On examination, the mass was hard in consistency. It was not tender. It was involving the right hypochondriac and epigastric region. The surface was nodular with irregular edges and was moving with respiration. So, an asymptomatic mass in the right upper quadrant involving the right hypochondriac region. Now that and it was moving with respiration as well. Now that takes me towards liver as the organ of origin. Now the liver lesion, it could be benign or malignant, but on examination, I found that the surface was nodular and the edges were irregular and the mass was hard in consistency. That took me more towards the malignant side, ma'am.
And can I ask? Hello.
Yes, sir.
Can I ask in the examination, because you have come and summarized the case very nicely. Few things I would like to know about examination also,
Yes,
because
sir.
you have mostly confined your mass in the right side, right hypochondrium, right?
Yes, sir. Yes,
So
sir.
rest of the abdomen is normal.
Yes,
Have
sir.
you seen the genitalia of the patient?
I have seen the genitalia, sir.
Yeah.
The genitals were normal and the bilateral testes were descended as well. The scrotum was well developed as well.
Okay. There was no any swelling on the inguinal area.
No, sir. Bilateral hernial orifices were normal.
Okay, okay. Go ahead, go ahead. Okay. So I think with history and examination finding, they are suggestive towards what she has told, that is the more towards the malignancy. But what other things you can think, being a hard mass, irregular things other than malignancy, can be anything else in that particular area?
So, in the right hypochondriac region, if we think about the organs of origin, it could be liver, it could be gallbladder, it could be, in fact, the kidney as well.
Yeah.
So, if we're thinking about the diagnosis, it could be benign, it could be malignant. But this age at 11 months has presented to us. And if we think about this age, then the lesion involving the liver could be benign or malignant. The benign could be infantile hemangioma as well, sir.
Yeah, that could be the possibility. Can anything else other than liver or kidney and the pancreas, you can think for hard swelling in that particular area? Sometimes you can get in any part of the abdomen, but that can also on the right hypochondrium also. Any solid mass like retroperitoneal teratoma.
Retroperitoneal teratoma, yes, sir. It can be
Yeah,
in
that
the
can
other
be
part of the
also,
abdomen.
but that you can exclude by later on by doing the various investigation. But thinking and examining, you can keep the possibility of this tumor also. Although it is rare, fully agree with you, but sometimes you can ask. Okay.
Sir.
Okay.
Can
Now
we keep a neuroblastoma in place, Soumya?
Yes, ma'am. Sorry,
So
ma'am.
how do you plan to rule it out, a large right-sided neuroblastoma crossing the midline? Like this tumor has crossed the midline, irregular, nodular.
Yes, ma'am. Yes, ma'am.
Then
So, ma'am, neuroblastoma can actually present with the right hypochondriac mass as well, but the presentation of the child would not be well preserved in that case. The child would be more of a cranky child. It would be a sick-looking child, irritable child.
Yeah.
And it will not be an asymptomatic mass. The child will keep on complaining of pain. He would touch the mass and keep on crying. That would be the presentation of this child if he had neuroblastoma.
and why did we look for precocious puberty? You said you ruled out precocious puberty.
So, yes, yes, sir.
Class join ಆಗಿದ್ದೇನೆ.
So, ma'am, according to history and examination and the age group as well, I was going towards more of liver with malignant lesion in this age group of 11 months. So I wanted to, so in my head, I had a diagnosis of malignant liver lesion, which could have been hepatoblastoma. And there have been studies in which it's been told that hepatoblastoma can release beta HCG as well, which can present with the features of precocious puberty also.
But what else can be nearby structure that can also lead to the precocious puberty?
Sir, any GCTs can secrete beta HCG.
What about the adrenal tumor?
Adrenals.
Agree?
Okay, sir. Yes, sir.
Adrenal tumors, 10 to 15%, they are non-secreting hormonal tumors, but the rest they have various hormones secreted by them. They can have lead to the precocious puberty, right? So
Yes, sir.
you have also think for.
Yes, sir.
Okay. So I think we can move for the investigation, ma'am.
Yes, sir, definitely.
So with these findings of history and examination, we went ahead with the investigations. According to the protocol, we first went ahead with the blood investigations on which the hemoglobin was 10.5. The platelet counts were 738,000. The AFP was 92, which was mildly raised for this age. LDH was 422 and beta HCG was 2.4. Then an ultrasound was done in which it showed that liver was enlarged and heterogeneous in echo texture with echogenic areas within, likely a neoplastic lesion. Following this, we went ahead with a CCT thorax, abdomen, and pelvis.
Can you show us the lesion with a pointer, Soumya? And can you
Yes,
read
ma'am.
out the CT scan for us?
Yes, ma'am. So, ma'am, we went ahead with the CCT thorax, abdomen, and pelvis for this child. Now, this is the CCT showing the abdominal region. First one is the axial section of CCT abdomen, in which this was the tumor mass involving right lobe of the liver with enhancing and hypoenhancing areas within, We are looking at the arterial phase of the tumor, arterial phase of the CT, because of which the tumor is being enhanced. In the coronal section as well, we can see that this is the liver mass, and the which is involving most of the right lobe of the liver. Almost whole of the right lobe of the liver is replaced by the mass, and the left lobe of the liver is hypertrophied. There is compensatory hypertrophy of the left lobe of liver because of the mass involving the complete right lobe of liver. Just a second.
Yeah.
Yes, ma'am.
Yeah. So why should a mass in the right lobe of the liver lead to a hypertrophy in the left lobe of the liver? Compensatory hypertrophy. What could be the mechanism here?
Ma'am,
Would you
because
be able to explain that on the CT scan as well as when you talk?
just a second, ma'am. I have to move the. Yes, ma'am. So, ma'am, this is the left lobe of the liver. This is the left lobe of the liver, and it is enlarged compared to what it would look normally. And there is compensatory hypertrophy, as in the right lobe is completely replaced by the mass. So, left lobe of the liver has to work for the whole part of the liver. That is why it has hypertrophied, ma'am. And this is where it is looking hypertrophied.
If I'm not mistaken, Rawat sir, you can also correct me. I thought a liver hypertrophy occurs not because of the parenchymal invasion of the tumor, but because of the portal vein getting thrombosed or getting compressed by the tumor when there is an extra added supply of portal vein to the non-affected lobe.
Yeah.
And a large amount of blood supply rather than a parenchymal invasion, Soumya.
We agree, ma'am. Agree.
Yes, ma'am. Okay, ma'am. The whole of the blood supply would be diverted to just the left lobe of liver, which will cause the hypertrophy of the liver.
Yeah. So can you show us the portal vein and other things in this? Is there
Ma'am,
any?
I have another slide of images as well. I have the virtual reconstruction as well. Just a second, ma'am.
Even in this film, you can comment on certain things which you did not.
Yeah.
Like
Can comment on the spleen, kidney, and other structure nearby lymph node. So we can understand what is the extent of the disease just beside the mass also.
I marked certain things. Just appreciate these things and tell us what they are.
Yes, sir. So this is the arterial phase of the CCT, in which the tumor mass is getting enhanced. Here, this is the branch of the hepatic artery. Okay, I'll just annotate. This is the branch of the hepatic artery, which is going towards the tumor on this section, coronal section.
What is this? What is this? And what is this?
Yes, sir.
Yeah.
This looks like the celiac branches from coming out from the aorta, sir, which is supplying the right hepatic, which is giving branch to the for the right hepatic artery as well.
Yeah, right. You need to identify these things. This is what I mean.
Yes, sir. Yes, sir.
They look little, hypertrophied and little dilated because supplying the tumor.
Supplying the tumor.
Yeah. Sorry to interrupt. I mean, examiners, I would request a pardon in interrupting in between.
Yes, yes. I'm just using my eraser to remove the So this is the venous. This is actually the portal phase of the CCT of the abdominal region itself. First is the axial section, and the second is the coronal section. We can see better in the coronal section here. So, like what is important in such a mass? This is the IVC. This is the IVC here. And tumor mass is mostly towards the right of the IVC, that is involving the right lobe of liver. And this is the portal vein. This is the portal vein going here, going in this direction, and which will go and branch in both branch and give right portal and left portal branches.
You said you had a reconstructed image, Soumya?
I do, ma'am. I'm just trying to change the slide, ma'am, here.
Any problem changing this slide?
No, sir. It's okay now. So we got the CCT reconstructed as well to see the proper vasculature surrounding the tumor and try for a virtual dissection as well. So this is serial dissection going on for the abdomen. This is of the arterial face itself, which is why we can see the tumor mass here. These spaces are basically the necrotic regions which are not visible in the reconstruction as well. Here, the child actually there was an incidental finding in the CT where we found that the child had ectopic right kidney as well. So these are the other reconstruction images of the tumor. Here we can see the tumor itself involving the whole of the right lobe of liver. Here, in this section, we can see that this is the tumor. This whole area is the tumor. This is the IVC. We're not able to visualize the right hepatic vein, although this is the middle hepatic vein going just beside the tumor. And this is the left hepatic vein. This again, like we saw in the previous section, this is the portal vein. Ma'am and sir, if allowed, I'll go to the next slide.
Thank you, Soumya. Go ahead.
Yes, ma'am. So this is how the CCT thorax, abdomen, and pelvis that we did was reported. Thorax, there was no abnormality identified. In abdomen, there was a single large ill-defined arterial phase enhancing and portal and delayed phase hypoenhancing lesion with small foci of calcifications and internal non-enhancing areas seen involving the segments 5, 6, 7, and 8. The dimensions of the tumor was roughly 12 by 8 by 12 centimeters. The tumor was displacing the middle hepatic vein towards the left side. The right hepatic vein was attenuated in caliber. The right main portal vein, its anterior and posterior branches were not visualized. The tumor mass was reaching up to the subcapsular location in the segment 6 and 7, anteriorly and laterally abutting the anterior abdominal wall with focal indistinct planes. Posteriorly, it was abutting the subcapsular portion of segment 6 and 7. it was mildly compressing the intrahepatic IVC for a length of around 1.7 centimeters without any intralaminar filling defect. The mass was medially crossing the midline and displacing the gallbladder. So an impression of large, solid, heterogeneously enhancing lesion with internal necrosis involving the right lobe of liver, likely hepatoblastoma, was made. It was pretext 2 on imaging with all the annotation factors negative.
Rawat sir. So Soumya, what are these pretexts that you're talking about? Why is it so important that we need to have a pretext here? Number one. Number two, what about the alpha fetoprotein? You think it is normal at this age group? Is it elevated? Can you tell us more about these two?
Yes, ma'am. About the management of the diagnosis that we've come to from the clinical history and examination, it seems more likely to be hepatoblastoma from the history and examination itself. Now, with that diagnosis in mind, we went ahead with the investigations, of which one of the major ones was alpha fetoprotein. So now alpha fetoprotein at 11 months of age, if we take roughly around 1 year, the normal level is said to be 13. The normal AFP for 1 year of age is 13. Now 92 is not very raised. If we're suspecting hepatoblastoma, it should have been, it actually goes into lakhs if we're suspecting hepatoblastoma. AFP is seen within lakhs, thousands and lakhs also. This was just 92, which was less than 100. That is why our diagnosis was not, we were not very certain on the diagnosis based on the investigation, but the CCT suggested hepatoblastoma. Now, if we are thinking of CCT based hepatoblastoma with AFP, which is 92, that is less than 100, that makes this hepatoblastoma, this tumor, even the as in the of the poor prognosis, because it is said that if AFP is less than 100 in hepatoblastoma, then the response is not very good. So that is what we kept in mind. Then for your next question, ma'am, pretext. So pretext is a staging. So there are certain societies that have worked for hepatoblastoma. The main of those are COG and SIOPEL. Now SIOPEL, which advocates pre-op chemotherapy, has given a staging system based on the imaging. Now, based on that, in that system, they've divided this pretext, that is pre-treatment extent of disease, into 4 categories: first, second, third, and fourth. And the basic idea behind is the contiguous free sectors. So if we are taking liver, the liver is divided into 4 sectors. Second and third being left lateral, 4A and 4B being left, second and third being left medial, 4 being left lateral, 5 and 8 being right anterior, 6 and 7 being right posterior. So now these are the 4 sectors in which the liver has been divided. And now about the pretext staging, it talks about the contiguous free sectors. So in pretext 1, there are 3 contiguous free sectors. It does not mention which sector, the number of sectors it is involving. It actually wants to tell us the free contiguous sectors. So in pretext 2, 2 contiguous sectors are free. In pretext 3, 1 contiguous sector is free. And in pretext 4, all of the sectors are involved. Now the notation factors are C, E, F, H, M, and PV. C is for caudate lobe. E is for extrahepatic metastasis. F is for focality. H is for hemorrhage. M is for metastasis. N is for nodes. P is for portal vein, and V is for IVC. In this case, none of those were involved. That is why annotation factors have been given negative.
So I think after history examination and radiological finding, your diagnosis is towards the hepatoblastoma. Agreed?
Yes, sir.
So we cannot think and go for any other differential diagnosis. Now, how we will proceed to manage this case?
Yes, sir. So there are different school of thoughts. The COG says that if it is pretext 1 and pretext 2 with AFP more than 100, and the histology is good, it advocates for upfront surgery. Cyopel tells us to give pre-op chemotherapy, neoadjuvant chemotherapy, and then go ahead with surgery. So now, for this specific case, as the AFP is less than 100, we would like to go ahead with histopathology first to confirm our diagnosis of hepatoblastoma here. So that is what we did, sir. We did an FNAC which showed features in favor of malignant small round cell tumor, which was favoring hepatoblastoma. And the histopathology as well suggested hepatoblastoma of fetal type. So following all of this, our diagnosis of hepatoblastoma was confirmed, and fetal type, as it is said, that it is of good prognosis as well. But in our institute, we follow Cyopel. So we went ahead, we're planning to go ahead with pre-op chemotherapy for this child. And then we'll go ahead with the surgery here, sir.
So what are the chemotherapy options for this patient?
So if we're thinking according to Cyopel, so Cyopel divides divides it into standard risk and high risk. In standard risk, it includes pretext 1, 2, and 3 with AFP more than 100. In high risk, it includes pretext 4, any annotation factors positive in pretext 3 and 4, and AFP less than 100. If these features are present, then it would be high risk. So Cyopel says that in standard risk, you have to give 4 weeks of neoadjuvant chemotherapy, which has to be cisplatin. And then go ahead with surgery after checking the response of chemotherapy, and then giving 2 cycles of adjuvant chemotherapy as well of cisplatin. In high risk, it tells us to give cisplatin alternating with carboplatin and doxorubicin. A pre-op total 6 to 7 cycles, then going ahead with surgery after checking the response of chemotherapy, then adjuvant cycles of cisplatin and alternating with carboplatin and doxorubicin. A total of 10 cycles have to be given in high risk. A total of 6 cycles have to be given in the standard risk, according to Cyopel, sir.
When does COG advocate neoadjuvant chemotherapy then? Does it advocate at all?
It does, ma'am. It actually has its own staging system as well. Other than this, it has EVAN staging system, on which it talks about complete resection, or if there's any gross residue left, if there is any incomplete resection, and if there is distant metastasis. That this is how EVAN staging under COG is done. Now COG divides it into very low, low, intermediate, and high risk. So in the low risk itself, sir.
We lost you there, Soumya. Can you repeat that what you said?
Am I audible now, ma'am?
Yes,
No.
we lost you for some time.
Yes, ma'am. So, ma'am, COG divides the cases into very low, low, intermediate, and high risk. In very low risk, it says that adjuvant chemotherapy is not required. But from low risk, it advocates adjuvant chemotherapy. And in actually now, COG AHEP 0731, there's a protocol that COG has given, which is being followed in US as well, in which it says that pretext 1 and pretext 2 with histology, good histology, which is pure fetal type, you can just go ahead with the surgery itself. But if it is pretext 3 and 4, then you should give pre-op chemotherapy. That is what it is now saying, COG. And in fact, ma'am, now what has happened is there are 4 societies. SIOP, COG, there is a society in Germany and another in Japan as well. Now, there have been 4 schools of thoughts on the management of hepatoblastoma. But there's a collaborative group that has come up, which is CHIC, that is Children's Hepatic Tumor International Collaboration. It has combined the databases of all these 4 societies. It has included a total of 1,605 patients, and now it has given its own protocol. It has divided the patients into different risk groups according to its own protocol, in which they have included annotation factors. They have included especially metastasis. They have kept age as a factor, in which they are putting 8 years as a mark. They're putting they're using AFP also. So based on all these factors, they've divided into very low, intermediate, and high risk, and then they're giving their own protocols.
So just I want to know, in your case, what could be the possibility of outcome in this case after giving a sort of chemotherapy?
Sir, yes.
Would you able to excise the mass, or you can think for some other things?
So preoperatively on imaging, when we saw the imaging, as we can see, that is very near to the great vessels, as in it is very near to the middle hepatic vein. It is very near, it is displacing and very near to the IVC as well. So going for upfront resection, in spite of it being pretext 2 and annotation factors negative, is not possible. And anyway, we're following SIOPL here. So SIOPL, according to that, we're going ahead with 4 cycles of pre-op chemotherapy. In histopathology also, it has shown to be pure fetal type. So hopefully we will be able to perform a right hepatectomy on this child after 4 cycles of chemotherapy and seeing the response.
So having the AFP as less than 100, should not it be going into the high risk category?
Yes, ma'am, it should be.
On one hand, you are saying it is pure fetal histology, which is favorable. On the other hand, we have a AFP, which is less than 100, which is unfavorable. So how do you prognosticate it now?
So, ma'am, although yes, the main reason of us going ahead with histopathology was the fact that AFP was less than 100. If it was more than 100, then we would have never gone ahead with the histopathology itself, because all the other factors were pointing us directly in the hepatoblastoma direction. It is said that if the age group between 6 months to 3 years, and if radiology is unequivocally saying hepatoblastoma, and if the AFP is more than 100, then you need not go ahead with the histopathology also. But here, because AFP was less than 100, we went ahead with histopathology to confirm our diagnosis, and we wanted to rule out other things. Actually, if the AFP is less than 100, the main issue is that it could be either rhabdoid type of tumor, or it can actually be small cell undifferentiated type of histology, which will direct us towards poor prognosis. So that would help us in the giving the chemotherapy and in prognosticating the patient as well. But in histopathology, it has come to fetal type. So we would like to give 4 cycles of pre-op chemotherapy, and we would like to check the response post the chemotherapy and then deciding on further management.
So what chemotherapy are you giving for this patient right now?
Ma'am, based on SIOPL, we're actually giving, SIOPL has not considered histopathology. So we're giving superplado for this one. That is cisplatin being alternated with carboplatin and doxorubicin.
So you have taken only the alpha fetoprotein into consideration, isn't it?
Yes, ma'am, less than 100.
Yeah. So that we are very clear now. Okay. Thank you, Soumya. Rawat, sir. Vikesh, I think sir is busy talking.
Yeah, ma'am. So are you done with the, management part?
I think so, Vikesh. Unless somebody, there are some questions on the chat box which you would like to take up.
I think there were a few suggestions.
Okay.
Professor Sumita Biswas suggested that in case of hepatomegaly, upper border of liver dullness should be mentioned, a very basic thing. Should be mentioned in a case presentation. CT volumetry can answer the hypertrophy tissue. And there were few answers from the participants. What are low AFP means in hepatoblastoma?
So low AFP, actually the marker has been kept as less than 100. But in the age group, as we see, normally the AFP till around 6 months, till around at least 6 months of age is anyway high in the child. So we have to make sure that our AFP levels are above than the normal AFP levels of that age itself. As in, when the child is born, a term child, it has AFP of around 46 to 50,000 and it can go as high as around 1.7 lakhs, the normal AFP levels in a neonate who's born. And it comes to a level of adults at around 6 months to 1 year of age.
Okay.
Thank you, Soumya.
Thank you. Let me, you can, I mean, ask one or two more questions by the time I set my screen sharing. Ma'am?
Okay. Soumya, what is the role of liver transplantation in a case of hepatoblastoma? But we haven't
Yes, ma'am.
spoken about transplantation, so let's finish even that.
Yes, ma'am.
Does it have a and if so, what are the indications?
So, ma'am, the indications of liver transplant, actually, it is said that if there is pretext 3 of tumor involving and with vascular involvement as well, then we should, these surgeries, if we're planning, then it should be done in the center with liver transplantation facility as well. So even that is the protocol that's been said in the recent consensus documents that have come. So pretext 3 with vascular involvement, pretext 4, multifocal tumors, the tumors of liver involving the hilar areas in which resection is not possible. In such cases, we should go ahead with liver transplant.
I think even post-text 3 and 4 also would fall into that category. What about the metastasis? What would you do for the lung metastasis? Because it metastasizes to the lungs, isn't it? What would you like to do?
So, ma'am, around 10 to 20 patients, in fact, even in the pretext 1 and 2 stages, can present with lung metastasis. So, it is said that with the pre-op chemotherapy, these metastasis resolves. If not, the chemotherapy, then we can do metastasectomy as well in such cases.
Sorry, a good presentation. I was just holding some phone, important phone came. Just I wanted to know any role of intra-arterial chemotherapy. Have you read in this relation?
Yes, sir. Yes, sir. So in the cases where chemotherapy, the child has not responded to chemotherapy, there's another modality of treatment, which is TACE or HACE, which is trans-arterial chemoembolization.
Yeah.
In which the idea that the tumor is basically supplied by the artery. The hepatic artery is the main supply of the tumor. So if that is embolized with chemotherapy, mostly platins, that is cisplatin and doxorubicin class of drugs are used, which is, for example, pirarubicin, that is used for embolization of that vessel, and it should help us in the treatment. It is in fact nowadays said that in fact in the case reports, there have been case reports in which just with the use of TACE, around 9 to 10 around 9 to 10 settings of TACE has completely resolved the tumor. The AFP in a few case reports has come down from lakhs to normal levels, and the tumor has completely gone in the imaging just by the use of TACE, sir.
Okay, good.
Thank you.
I think there is a many query in the chat box. So, Dr. Vikesh, can you read and we can discuss if time is permit?
I'll take up the queries. First, we'll go to rapid fire round.
Okay.
And here it goes. So you are supposed to basically identify the diagnosis, radiological diagnosis, tell few important radiological key findings. Soumya, first one for you.
Yes, sir. Sir, I am seeing a CCT abdomen showing coronal and axial sections. I can see that in the coronal section, there is left kidney involvement and it is showing the claw sign as well. So it should be a Wilms tumor.
So you are right, it is a Wilms tumor. So it is showing a renal mass, which is a well circumscribed mass and hypoattenuated lesion, which is not crossing midline. There is no calcification, patchy enhancement. There is calicial distortion and destruction, a very important point, which is peculiar to Wilms tumor as compared to neuroblastoma. And not in this case, but you may find other findings like thrombus, renal nodes, and bony metastasis. So that claw sign you appreciated, that is a very good thing, because this is known as claw sign, this one.
Good.
This is claw sign. Okay. Move on to the next one. It's not moving. 1 second. I'll again share it. I don't know what is happening. Just give me a moment, please. Sorry for that. I don't know why it is happening. It was opening well. Yeah, okay. So now this one. This
So
one.
this is, yes, sir. So this is a CCT abdomen showing axial section in which I can see a mass on the left side of the abdomen. The right kidney is visible properly. Left kidney seems compressed. There is encasement of vessels as well. I can see the major vessels being encased. So it looks like neuroblastoma, which is crossing midline as well.
So all these findings are correct, except one thing which you missed is ascites here.
Ascites, yes, sir.
Yeah. So if you compare the tumor which you see in Wilms tumor, here you see a very irregular margin of the tumor. And kidney is displaced, there is no distortion, there is no destruction of the kidney. Now coming to these images, identify them and explain them.
Yes, sir. So I am seeing a CCT abdomen showing axial and the coronal sections.
Different
all of
scenario, not one patient, different patients.
In the first CCT of the abdomen region showing axial section, I can see there is a mass on the left side of the abdomen, which is which has calcification. There is again encasement of the vessel. So it looks again like neuroblastoma itself, sir.
And crossing midline.
Crossing midline.
Second one.
Second one, the axial section of CCT abdomen showing mass on the showing mass on the left side with calcification.
So this is basically to show the types of calcification.
Types of calcifications only in neuroblastoma.
So
Okay, yes, sir.
Speckled pattern of calcification you see in this mass. Here you see coarse calcification. Okay. So this is a suprarenal mass, again having a calcification.
Calcifications.
Just to highlight a point that various types of calcifications are possible in neuroblastoma.
Yes.
This one. Image 1 and image 2, two different patients.
Yes, sir. I'll just
Tell me the sign. And what is the diagnosis?
this one. Drooping.
Yeah. Yeah.
It seems like a drooping lily sign, sir.
Very, very correct. So drooping lily sign in both the images. So what is the difference between the two images? These are the two conditions in which you see drooping lily sign. That's why I put the two images.
Yes, sir. One is the duplex system.
Yeah, very good. So this is the first one is duplex. There is no mass lesion here. The upper pole is not enhanced because it must be like non-functioning, and it is must be dilated and compressing the calyces of the lower system. And you see only 3 calyces here. So one calyx is grossly missing here, which is the upper polar calyx, which has not enhanced. And there is a drooping lily sign. While here you see a mass lesion with calcification. So this is, here you see 2 prominent calyces very well. So there is no deficient calyces here. But there is a mass lesion in the suprarenal region, which is calcified. So this is a case of neuroblastoma, and this one is a case of duplex. So this is in summary, drooping lily sign is seen in neuroblastoma. It displaces the kidney, but does not distort the renal architecture, unlike Wilms tumor, which disrupts the renal architecture. While in calcification, neuroblastoma is usually axial calcification in 85% cases, but rarely you may find stippled calcification also, while there is no calcification in Wilms tumor. So key points about neuroblastoma: irregular lesion, suprarenal origin, crossing midline, calcification I explained, patchy enhancement, calyceal displacement, drooping lily, encasement as you identified in all the images very well, presence of regional nodes, and usually bony metastasis or spine metastasis common. Now, this is the same patient, 3 different sections in the portal venous phase. Identify the diagnosis and explain it.
So I'm seeing, yes.
Enhancing liver lesion, which is enhancing a little bit delayed in the portal phase.
Delayed enhancement in the portal phase. So, can I ask about the age of this?
Please. Age, that I don't know, but must be like 1 year, suppose like 9 months.
So,
okay, fine. So someone is telling hepatoblastoma. It is not hepatoblastoma. You see peripheral lesions.
Hemangioma.
Like hemangioendothelioma. Because hemangioma will enhance in the arterial phase. So there is a peculiar delayed enhancement in the portal phase, peripherally located lesions, multiple small lesions located peripherally. As you see, this is a peripheral enhancing lesions you see in all the images, all over the liver. It's hemangioendothelioma. Again, my slide is stuck. I don't know why it is like that. Yeah. This is one more sign you see in the same disease. Now you identify the sign. In the same disease, hemangioendothelioma. The reconstruction of the aorta. So here you see there is narrowing of the aorta below the celiac trunk. After the celiac trunk has opened in the form of hepatic artery into the liver and supplying the tumor, there is decreased caliber of the urethra below that. This is known as mid-aortic syndrome. So typical key points of hemangioendothelioma: multiple small circular enhancing lesions located peripherally, peripheral enhancement, delayed portal phase enhancement, reduced aortic caliber below the celiac trunk, mid-aortic syndrome, And if at the same time, you may find hepatic artery and celiac artery hypertrophied, as we saw in your particular patient. This one. Two different patients, two different diagnoses. Identify.
Fetus in fetal level.
Easy
This
one.
is yes, sir. This is I am seeing MR abdomen here, sir. No.
This is not MR because the bone you see
Bone
white.
is CT. It is CT. It is CT.
Okay.
Okay.
Bone if you see white,
Yes, sir.
then it is
Yes,
not
sir.
cannot be MR
It is
because
not
it
it.
always
Yes,
signal void in both T1, T2 images in MR. So this is CT. Fine.
yes, sir.
So you see bone there. It's an easy one. Give a try. You will be able to do it. It's a well circumscribed lesion lying retroperitoneally with mixed attenuation. Bony density also, fat attenuation also, soft tissue, fluid, everything is there. All components are there.
Teratoma, sir.
Teratoma. And what about this?
It has. I can see teeth. Like
Yeah, maybe bone or teeth.
yes, sir.
But how this is different from the previous one? What is peculiar about this image? You see a spine. So presence of a spine denotes that it is fetus in situ. So
Okay,
basically,
sir.
it's a teratoma only.
Okay,
But
sir.
presence of a spine is the criteria for diagnosis of fetus in situ. So you see presence of spine here, that's why it's fetus in situ, although the management doesn't vary. So teratoma key points, mixed density lesion, macrocalcification, bones, fat attenuation, benign, well circumscribed lesion. In malignancy, there may be enhancement or invasion, and presence of spine is characteristic of fetus in situ. Last one. This is the ultrasound image of a young girl presenting with epigastric mass, tender mass, the CT scan of the same patient.
So there is on the CCT abdomen, there's a lesion overlying the pancreas, sir.
Can you mark it? This one? Or this one? On ultrasound, what do you see? It's very characteristic sign. Young girl, 12, 15 years old, having epigastric pain and a lump in the epigastric region.
I can see hypoechoic lesion, sir. There is hypoechogenicity.
So what you see here is a linear arc of hyperechoic lesion. Linear arc of hyperechoic lesion. Okay.
Yes, sir.
Post-acoustic shadowing all over. You can't see anything behind that.
Okay, sir.
This is a hint. Linear arc of hyperechoic shadow with nothing seen behind it. Post-acoustic shadow is there. Here you see a mass lesion in the stomach as well as in the duodenum, which is surrounded by some contrast, which has been given orally. Contrast has not reached the mass, but you can see air densities in the mass. Now you will be able to make the diagnosis. Trichobezoa.
So is there any? Yes, sir.
So linear arc. So the characteristic key points. Again, the same problem. Slide is not moving. Okay, arc-like linear long acoustic shadow in the epigastrium. On CT scan, contrast encircling the lesion. Air densities in the lesion, mesh-like mass. And if there is like Rapunzel syndrome or it is extending in the small bowel, you may find meteoristic small bowel loops. This was all about today's rapid fire round. You did it really very well. So there are certain questions in the chat box. If I would like to take, yeah, few people made good diagnosis also there. Some wrong also. Sir, which question I left? What is the role of radio frequency ablation from Dr. Archika? Is there any role of radio frequency ablation for hepatoblastoma?
There is, sir. I have read in a few case reports, they have given radio frequency ablation as well for the child, along with the chemotherapy. I'm not sure of the indication. So,
It's homework for you.
yes, sir.
Mr. Zoom has asked why pre-op 4 cycles and not 7 cycles?
So it depends on the standard and high risk. If according to SIOPL, if we're following, if the child comes under the standard risk category,
Your
then
case was high risk because
AFP was less than 100, sir. So that is why it came under high risk. So if it was standard risk according to pretext 2 and annotation factors negative, and if the AFP were more than 100, we would have given 4 cycles of neoadjuvant and 2 cycles post surgery, totaling it to total of 6 cycles. But our case, because the AFP was less than 100, it came under high risk. So that is why we've given super plado. Total of 10 cycles have to be given, around 6 to 7 pre-op, neoadjuvant, and 3 to 4 post-op. The super plado consists of cisplatin alternating with carboplatin and doxorubicin.
Hope this answers the query of the participant. Thank you and very well done. Soumya, you presented very well and defended the question quite nicely. Thank you both the examiners for your patient participation as well as very active Viva OC. I'll request our president, Dr. Ramesh Babu, to kindly say a few words and make some announcement if needed. Dr. Ramesh Babu.
Thank you, Vikesh. Can you hear me?
Yeah, please.
Yeah, very well done. Today's session was really good. I wish all the PGs join, and also all the other senior members who are there can actually join and then, give a lot of encouragement for the students, ask more questions. It is a very good session today. And then a very good number of participants also, like more than 50. And thanks to Dr. Rawat and Satyashri for taking an active participation in this. And the candidate also very well done. Indeed. Just as a thought, while this session was happening, Dr. Vikesh was having a suggestion, and then I quite agreed with that idea. Just to encourage the students, we are thinking of announcing prizes for the best mock exam performances. And first 3 prizes of all the mock examinations happened during this this entire before the IAPS con will be considered. So the ones who pass now and then the ones who will be passing the next year also will be contesting. And then one of us will judge based on a subject, not the objective way of assessment. We'll have some objective way of content, the clarity, the boldness, and then how you answer the questions and how you rapid fire assess. All those things will be assessed. If I'm not there, Dr. Vikesh will assess, but he is not there, I will assess. But because it is an objective way of assessing, we will come out with some kind of a prize. So at the IAPS con Rishikesh, definitely 3 PGs will have prize from IAPS for their best performance. So I want all the PGs to come very well prepared and then, live up to the challenge and then, make us proud. Anything else, Vikesh?
Yes, thank you very much for accepting my suggestion. And again, I thank all the participants. Still, we think that we need to increase the number. And as you see that this is going to become more popular and we will do certain interventions to make it more interesting. Thank you again, both the examiners and the student, for joining this meeting.
Thank you, Vikesh ji. Thank you.
Thank you.
Thank you all so much. Thank you.